and welcome to this Clinical Care Options podcast episode. This episode is a featured component of an educational program titled Optimizing Patient Outcomes in IgAN, Expert Guidance on Evolving Management and Treatment Options. I'm your host, Kim Neely, and today I'm excited to be joined by our amazing faculty who are experts in managing and researching about IgA nephropathy. Dr. Pietro Canetta and Dr. Andy Bomback are both associate professors of medicine at Columbia University in New York, New York, focusing their clinical and research endeavors in the area of glomerular diseases. Today, they will give us the latest updates in managing IgA nephropathy. To find more activities on IgA nephropathy, including a CME certified text module with animated video and patient voice audio clips, clinical thought commentaries, and more, visit clinicaloptions.com or visit the link in the show notes. Now I'm excited to hand it over to our guests.
Well, thanks very much for the introduction. My name is Pietro Canetta. I am an associate professor of medicine at Columbia University, New York City. I'm very happy to be here today, joined by my colleague, Dr. Bomback. Would you like to introduce yourself?
Sure. My name's Andy Bomback. I'm also associate professor of medicine here at Columbia University. And Pietro and I work together at the Center for Glomerular Diseases, where I think it's safe to say, Pietro, that the number one diagnosis that we see is IgA nephropathy.
Yeah, I think that's true. And so we are happy to have been invited to speak about the therapeutic approach to managing IgA nephropathy today. This is an exciting time, I think, especially the past sort of 4 or 5 years, where we've gone from having very, very little specifically to treat this disease to now having actually indicated FDA-approved agents specifically for this disease. So as somebody who studies the disease and treats it in a university setting, it's very exciting to see so the fruits of our labor, our colleagues, researchers, physicians, scientists, industry, everyone who's helped bring these agents to market and to see them being put in place to try to help patients.
Yeah, I mean, I think it's so exciting in terms of what we have in our armamentarium now to potentially treat IgA nephropathy. I think, most of the consults we've gotten about IgA nephropathy over the last decade have really been the simple question of, should I put this patient on steroids? But now when we get new IgA nephropathy patients, there's so many things we opine about in terms of the treatment beyond just should this patient get immunosuppressed. We often think about just how expansive supportive care is for IgA nephropathy. And then when we think about immunosuppression, there's a bunch of different options that we have now on top of steroids. So maybe best to start just talking about the supportive care that we do for IgA nephropathy before we even get to the immunomodulatory treatments.
Right, supportive care. So that's, if you look at the KDIGO guidelines, that's sort of the primary recommendation that's been made now for years. And I think is still, I would say safe to say for you and I, still the first thing that we sort of do when we're looking at a patient who's been diagnosed. I always tell the patients, I always make it really clear up front, this is going to be a long haul. This is a disease that generally does not go away on its own. Once you've been diagnosed, for the most part, you end up having it for life, but it is manageable. It's manageable, but it takes attention to it, and it often does take medications taken for a long time. And so the first step is this supportive care. So what's supportive care for our listeners is all those sort of interventions that we can make that are going to be generally good for somebody who has chronic kidney disease or kidney disease with protein in the urine of all flavors, of which IgA nephropathy is one type. So these are things that are not necessarily specific to IgA nephropathy, but are generally good for proteinuric kidney disease. Things like blood pressure control, managing a healthy weight, reducing sodium intake, and things like that. And then there's additional medications. And I think one of the changes in the past few years about supportive care has been widespread use of a type of drug called an SGLT2 inhibitor. So, Dr. Bomback, what's your approach to the use of SGLT2 inhibitors in patients with IgA nephropathy?
So I use SGLT2 inhibitors in anybody with IgA nephropathy who has chronic kidney disease. So that's a pretty broad definition because you can call it chronic kidney disease if they have a reduced GFR, or you can call it chronic kidney disease if they have proteinuria. So I pretty much for every IgA nephropathy patient, I'm asking myself, does this patient deserve to be on SGLT2 inhibitors? And I'm almost always saying yes. And I think, when I think about where supportive care for IgA nephropathy is compared to, say, 10 years ago, it was everybody should be on an ACE inhibitor or an angiotensin receptor blocker. Now for IgA nephropathy, and I think about sort of managing their CKD component of IgA nephropathy, and this would go for pretty much any glomerular disease. I'm almost thinking of a 4-drug regimen for everyone. It's an ACE or an ARB. It's a mineralocorticoid receptor antagonist if they can tolerate that on top of the ACE or ARB. It's an SGLT2 inhibitor, and I think we're headed in the future to possibly adding a GLP-1 agonist on top of the SGLT2 inhibitor. So that's a really expansive supportive regimen for these patients.
Yeah, and I've also found myself using SGLT2 inhibitors really with increasing frequency, really for almost all my patients with proteinuric kidney disease, certainly for IgA nephropathy. There's been 2 very large studies of diabetic and non-diabetic chronic kidney disease that included hundreds of patients with IgA nephropathy, the DAPA-CKD study and the EMPA-Kidney study. EMPA-Kidney had over 800, DAPA-CKD had nearly 300. And they showed that the benefits of these drugs in slowing kidney function are really maintained and very similar in that subgroup of patients with IgA nephropathy. So you can tell your patients that there's really good evidence that it slows down their disease, and the drugs are generally very, very well tolerated. I think for me, the other thing I'll say is that the more proteinuria there is, I think the more benefit, and that's been shown in some of the subgroup analyses that that the effects seem to be proportional to proteinuria. So if somebody is doing really well and has absolutely no proteinuria, which is rare, but if that was the case, that would be the person where I might not add it, but otherwise I do use them broadly.
Yeah. Now that we've cracked the nut on supportive care, then I think the next question we always get is, do they need more than supportive care? Do we need immunomodulatory therapies? So what makes you think about using immunosuppression in an IgA patient?
Yeah, absolutely. And this is where things have probably changed the most in the past few years. But even as of a few years ago, I think we would use and still occasionally do systemic glucocorticoids like prednisone, oral prednisone. And we would do it in patients who, despite supportive care, for a reasonable period, something like 12 to 24 weeks of really doing a good job, still had a lot of protein in the urine, which is a marker of sort of ongoing disease activity and long-term disease risk. And I think we've always integrated our interpretation of the kidney biopsy into that as well. And the more recent a kidney biopsy you have, the more you can use those that data to really have a sense of what's going on. But when you see a lot of inflammation in the kidney biopsy, that would also push me to using immunosuppression. So as of 4 or 5 years ago, all we had was systemic glucocorticoids, and they worked. I think there's good evidence that they worked from the testing study. They reduce protein in the urine, they reduce kidney failure events, but they come at a cost of a lot of side effects. And that's been one of the nice changes of the past few years, that we're seeing alternative agents like targeted budesonide. What do you think about targeted budesonide, and how do you use it in your practice?
So I think what you said about steroids is really important because the efficacy data still is there, but you're really concerned about the toxicity. So I tend to use targeted release budesonide as my first immunomodulatory therapy in someone that I highly suspect is going to have toxicity with steroids. If it's someone that I have a very low suspicion for steroid toxicity, I tend to use the low dose testing protocol first, just because steroids are so easy to get and so economic available for all of our patients. But if there's someone with diabetes or obesity, or someone who's had previous courses of steroids, that's the kind of person that I'm tending to go right to targeted release budesonide.
Yeah, I agree. And this is a drug that was approved right at the end of 2021. So it's just been around for a couple of years. The treatment is a 9-month course is the standard course.
Yeah.
And I think one of the other things about it is if the person is not does not have terribly aggressive disease, you can always make the argument that you treat for 9 months. And if for some reason they don't have an optimal response, you could always go back to using systemic steroids after. I have to say, in somebody who's already been treated with systemic steroids, I'm much less likely to try the targeted budesonide subsequently because I'm not sure how much more bang for my buck I'll get from it.
Yeah.
The next drug that was approved about a year after that was sparsentan, which is an endothelin receptor antagonist, and it's one of at least 2 which are being studied for IgA nephropathy. So how do you use sparsentan in your own practice?
Yeah, so I think of sparsentan and any other endothelin receptor antagonists as more part of the chronic treatment of IgA nephropathy rather than the way I think of some of these immunomodulators as an acute treatment of IgA nephropathy. So I'm tending to use sparsentan, and if another endothelin receptor antagonist becomes available, I would use that class of agents as a more robust antiproteinuric therapy in somebody who has a chronic form of IgA nephropathy. So someone who's already done a course of immunosuppression, is already on an ACE inhibitor or angiotensin receptor blocker, and still has more than 1 gram or 1.5 grams of proteinuria, that's the kind of patient I would be very, eager to try to switch over to a drug like sparsentan, where you're getting both an endothelin receptor antagonist and a angiotensin 2 receptor antagonist in the single drug, because the proteinuria reductions in the trial were better than an ARB alone, and the rate of GFR decline was slower. So what I'm really trying to do is get that proteinuria as low as possible. With IgA nephropathy, as you know, you lecture so well about this, the linear relationship between proteinuria and progressive risk of kidney disease really says there's really no level that's too low. You want to keep lowering the protein as much as you can. And that's where I think about using the endothelin receptor antagonists.
Yeah, so it sounds like what you're saying is you sort of think of them as an addition to supportive care.
Yeah, exactly. But if I'm looking to try to get that acute treatment, if I get someone who just got biopsied as endocapillary proliferation, that's the type of person where I'm thinking more about using drugs that I know modulate the immune system and go after some point of the multi-hit model of IgA pathogenesis, whether it's steroids, targeted release budesonide, or this newest drug that was just approved by the FDA, iptacopan, which goes after factor B and the alternative complement pathway.
Yeah, and so I'd love to talk more about that, but to sort of wrap it up, sometimes we're asked, how do you choose between targeted budesonide and sparsentan? Because those are the 2 drugs that up until very recently had been FDA approved. And I've always said I don't choose between them. It's not an either or. I think they have different roles exactly because of what you said. They act in different parts of the multi-hit pathogenic development of the disease. And so I use them also differently. And sparsentan, as you said, much greater proteinuria reduction than an ARB alone. It does have that ARB effect. The downside of it, there is a REMS program that the patient has to commit to be in it. Obviously, it's a new drug, which is costly, and we are still waiting for the full FDA approval. It still has the accelerated approval. But speaking of accelerated approval, so just recently we've heard about the accelerated approval of iptacopan. So this is a complement acting drug, and it's a factor B inhibitor, so it acts on the alternative complement pathway. And were you surprised at all that this drug got approved?
I was not surprised it got approved, because if you look at how the FDA is approving drugs for IgA, they've accepted proteinuria reductions as a surrogate, and the proteinuria reductions with iptacopan were similar to what were shown with budesonide and sparsentan. So I think everybody was sort of expecting that it would get approved. And I also wasn't surprised that it works, because many really well done studies, including from some of our colleagues here at Columbia, have highlighted the important role of the alternative complement pathway in the pathogenesis of IgA nephropathy, both in the assembly of the immune complexes of IgA nephropathy, but also in that inflammatory response that ensues after those immune complexes deposit on the kidney. So blocking complement would be expected to have a beneficial role in IgA nephropathy. And now we have an agent that can do that. So that's very exciting.
Yeah, and I know that we're very excited because of work that we do in other rare kidney diseases, like our C3 glomerulonephritis efforts that Dr. Bomback's particularly involved in. And seeing a complement agent approved for kidney disease is really exciting because they're thinking of other diseases that have overlapping effects, which IgA nephropathy is often a model for these other forms of chronic glomerulonephritis.
Yeah, and I think all of this is a testament to what clinical trials for our patients have been able to do. IgA has had just a huge interest in clinical trials over the last decade, and it's borne a lot of fruit with new drugs being approved. And there are still plenty of clinical trials that are ongoing. There are trials that are specifically looking at drugs that block the APRIL and BLyS pathways, and those trials, their early results also show very impressive proteinuria reduction. So I think, many of us expect that those kinds of drugs could also have a pathway to approval. And this is really a great situation for our patients to have multiple agents that are available for IgA nephropathy, each one going after a different part of the pathway, is really great for our patients. Because as we think about the ideal goal of precision medicine, especially in a disease like IgA nephropathy, to be able to pick and choose different options really gives our patients as many chances as possible to halt the disease, to slow progression, and to really have good long-term outcomes. So still working with clinical trials is a crucial part of our work with IgA nephropathy here at Columbia at the Center for Glomerular Diseases.
I think that's a great place to wrap it up. And so in summary, if you're a clinician who treats IgA nephropathy or a patient who has IgA nephropathy, we have 3 FDA-approved drugs on top of a really well-developed approach to clinical treatment. Just in the past few years, the future holds a lot of opportunities because of the additional really, really good-looking drugs that are in development, at least good-looking early reports. So please continue to be involved in research, refer your patients for research. If you're a patient, become involved in research. And I think if there's one lesson that or one theme that we'll leave you with is that the future in this disease is very, very bright. So thanks very much for listening, and we hope you enjoyed the conversation.
Thank you so much to Dr. Canetta and Dr. Bomback for joining us for this very important discussion about updates in managing IgA nephropathy. And thank you for listening. As a reminder, visit the episode notes or clinicaloptions.com to find more educational activities on IgA nephropathy.